احمي مريضك من الدواء المزور. احمي مريضك من تجار الدواء الغير شرعيين. احمي مريضك من المصادر المجهولة. صحتنا أولوية.
Welcome, everybody, and it's great to have everybody for another IBD Grand Rounds. We are excited to be back with you, and hopefully everybody is healthy and safe. And we're looking forward to two exciting cases today with some good multidisciplinary discussion. Our first case is, and I'm Benjamin Cohen from Cleveland Clinic in Cleveland. It's snowing here. Hopefully you all are warmer than we are right now. Unfortunately, my colleague, Dr. Florian Reeder, wasn't able to join us today, so I'll be taking the reins for both cases. And we're going to start with our first case, which should spark some interesting discussion around extraintestinal manifestations and paradoxical reactions. And for that, we have Dr. David Epstein from South Africa, who's in private practice gastroenterology and also runs a nonprofit, IBD Africa. So I will send it over to you, David, to get us started.
Great. Well, thanks very much for the invitation to speak at this meeting. Thanks to Alla and Ben for inviting me, and it's the first time I'm presenting at this Middle East IBD meeting, and thanks very much for the invite. Case, puzzling pyoderma, potassium permanganate, and poor adherence. And I think the reason for that title will emerge during the talk. So I think it's just a time at the end of the year to reflect on where we are at the moment. And I think it's, while we're all sitting in the comfort of our homes, think of others who maybe are less fortunate than ourselves in the world at present. So the case I'm going to present is a 33-year-old male who I first saw 12 years ago, in fact. He's from the UK, but had moved to South Africa, and he'd had an extensive travel history. He'd traveled mainly in sort of developing countries. He'd been treated for typhoid and malaria in the past, and he has a brother with Crohn's disease. And he presented with a 3-month history of some loose stool with blood and mucus. There was urgency and tenesmus, and he had had 2 episodes of incontinence. And he'd lost some weight and was feeling fatigued, but he reported no extra intestinal manifestations of IBD. He had stopped smoking recently, and he had normal laboratory tests. And a colleague of mine had performed a sigmoidoscopy and identified a proctitis that was very suggestive of ulcerative colitis, and the biopsies confirmed UC with architectural distortion and Paneth cell metaplasia. There were no granulomas or infection, and he was started on 5-ASA therapy, both orally and topical. So he was referred to me, and I suggested he have a full colonoscopy, which he came back a few months later. And in fact, the scope looked remarkably normal. I wasn't able to intubate the terminal ileum, and we managed him as an ulcerative proctitis. And in our practice, there would be some scope for self-management and adjusting medication according to symptoms. And I reassured him that, proctitis was unlikely to lead to cancer or the need for surgery. I didn't see him for 6 years until he was admitted via our emergency unit with quite long-standing symptoms of severely active IBD. He had been relying on alternative therapies. He had lost a significant amount of weight. He had fever, was very fatigued. He also complained of severe backache and early morning stiffness, and he had a perianal abscess. And his laboratory tests were very consistent with a severe flare of IBD, and he was tested positive for HLA-B27. So we performed a endoscopy, a sigmoidoscopy, which showed what looked like severe Crohn's disease with deep serpiginous ulceration in the rectum and sigmoid colon. And the biopsies confirmed, IBD, but no granulomas. He had an anal tag and a perianal abscess. A CT scan of the abdomen confirmed a severe colitis, but the small bowel appeared normal. And his MRI showed quite severe sacroiliitis, and you can see on the red arrows marked edema and erosions of the sacroiliac joints, whereas the yellow arrow shows more preserved SI joints, more posteriorly, I think that is. So we revised the diagnosis to Crohn's colitis, perianal disease, and ankylosing spondylitis. And he was treated in the following way. He had an examination under anesthetic, and a small ischiorectal abscess was drained, but there was no fistula. He was started on IV steroids, but rapidly escalated to infliximab in combination with methotrexate, and some sulfasalazine was added for some peripheral arthritis. And we followed him up over the next 3 years, and he did really well. He went into excellent clinical and biomarker remission. He continued on a conventional dosing of infliximab, and his methotrexate and sulfasalazine was weaned. And the only sort of blip on the sort of radar was a small perianal abscess in 2020, which did not require drainage and was treated with antibiotics. And a TDM at the time showed that he had a therapeutic trough level, although not particularly high. And during this time, we had regular visits because he was coming for infusions. He was still traveling quite a lot in Africa, and we counseled him regarding use of alternative therapies, particularly discussed malaria prophylaxis because he was traveling to malaria areas on the continent. And I think his overall health literacy improved over the years that he was under our care. He then presented in November saying that he had developed some ulceration of his lower left leg. And just looking at the lesions, it looked very much like pyoderma with a violaceous sort of border and sort of undermined edges. But there wasn't much pain involved or pruritus. And he said the lesions would start as an erythematous nodule and then enlarge to form an ulcer. So he had seen 2 dermatologists.
So maybe let's go back to the other side, and we can talk to the panel at this point. So we have this patient who initially had mild, what we thought was ulcerative colitis, treated with topicals, and then later on comes to present with severe Crohn's colitis with perianal disease, and seemingly had a good initial response to infliximab plus methotrexate. So I'm going to go to Dr. Kutubi first, and then I will go to Dr. Sadeghi. Disregard the skin manifestations we're seeing now, but what I want to talk about is your management of infliximab plus methotrexate. So this patient continued on combination therapy with their perianal disease. What's your normal approach with combination therapy? Are you continuing patients for the long term on the combination? Are you removing the immunomodulator? So Dr. Kutubi, and then also what's your, how do you utilize therapeutic drug monitoring for these patients?
Yeah, thank you, Ben, and thank you, David. This is a very interesting and nice presentation. Now, from our practice, actually, I use methotrexate and I keep the patients on it for a few years. I don't mind on that. But when we use azathioprine, usually 6 months to 1 year maximum, I don't go beyond that. So that is because for the use of combination. Now, for the TDM, usually when I see these bad ulcers in the colon with the extraintestinal, I usually like to have a higher infliximab level than 5.9. Usually 10 and above should be actually good. And always we coordinate to have an MDT meeting with our dermatologist to see how they can, what can we do. But we know that this, sometimes can parallel the disease activity, and the better control of the disease, the better control of these dermatological manifestations.
So in terms of the drug level ideal being above 10, which is also what I tend to utilize for infliximab, if you have a patient who's feeling well, but their drug level is less than 10, are you dose escalating even though they may be asymptomatic?
We don't, but if it's under control endoscopically, biopsy, and no other extraintestinal manifestation, I'm happy with 4 and 5 if the patient is doing well.
Okay. And Dr. Sadeghi, anything different in your approach to managing combination therapy?
Hello, everybody. Actually, combination therapy lead to typically enhance treatment efficacy and reduce the formation of anti-drug antibodies and maintain higher level of the biologic drug in the body. And because of that, it is acceptable. And we add actually methotrexate and azathioprine to infliximab for prohibiting the antibody level production in the body. And in order to reactive checking the antibody and drug level, yes, in very high risk patient and in severe patient. For example, when we have a young man with, for example, Crohn's disease, fistulizing Crohn's disease, we tend to check antibody and drug level proactive without any flare or disease activity. But in some cases, we decide to perform it and prescribe it reactively after some events.
Yeah, we could probably have a whole case conference just on proactive or reactive drug monitoring. I would say my approaches are generally similar in that I usually start anti-TNF with an immunomodulator, whether it's methotrexate or azathioprine. I tend to stop the second agent after 6 to 12 months. Oftentimes this is because our patients are concerned about side effects, and I'm usually using the second agent as Dr. Sadeghi said, to boost the drug levels of the anti-TNF. So if I have optimal drug levels, I'll usually stop the secondary agent. The one situation where that may not be the case is severe perianal fistulizing disease, where we may need to maintain combination for the long term. So now this patient presents with these skin manifestations, which I always dread because the last thing I want to be was a dermatologist, and I have no idea what I'm looking at most of the time when patients show me the pictures on their phone. So Dr. Sharara, what do you do in this situation? How would you approach this? What's your differential?
Yeah, I mean, I agree with David. They do look like PG, but what's strange is that they've happened a couple of years on treatment, the patient doing well, kind of like don't quite fit the usual pattern that we see. Normally, they're quite responsive to treatment, and multiple lesions kind of raise a little bit of a flag for me in that I usually will certainly get the help of my dermatologist or our dermatologist on that. And we're thankful to have Dr. Dana Saadi with us. She's a dermatologist at AUB who was joined us for this session. So please feel free to ask her questions.
Yeah. So that's where I was going to go next. So Dr. Saadi, thanks for joining us, and maybe you can enlighten us gastroenterologists about what are maybe characteristic about these lesions. Do they look like PG? How can we differentiate on our physical exam?
Yes, hi. Thank you for inviting me for this lecture here, presentation. So they do look like PG, and especially with the history of the patient, given that they start as a small subcutaneous nodule, and then they open up with this erythematous border and the center that is like granulation tissue in the center. So they do look like PG, and we see a lot of PG with Crohn's disease. So it's the first thing that would come to our mind among the long list of differential. Even if they are on treatment, we do still see, and this is important to note, so maybe the treatment is suboptimal, maybe the treatment is not working anymore. So this is important to see that the disease is progressing despite the treatment. So number one on the differential would be PG. Otherwise, we think of vasculitis, which usually also comes with Crohn's and does present with ulceration on the lower extremity. So this is also not something surprising to see. Something else we need to consider here is the list of neutrophilic dermatoses, which are usually either drug-related or to the initial disease itself, to Crohn's disease. So this is also something to consider. And these are all, we see them all in the biopsy, and they change a little bit in the management, because if it's neutrophilic, it's a certain specific treatment. If it's PG, it's a different treatment. So in such cases, we biopsy and we see.
Great. So, Dr. Epstein, what happened next?
Right. So the patient was seen by a dermatologist, in fact, two dermatologists, and a pus swab was taken and a Staph aureus was cultured. So he received repeated courses of our oral antibiotics as well as topical therapy. And then a biopsy was done. And the bottom line with the biopsy was that there was a granulomatous active chronic inflammatory process. The pathologist didn't really give us much more than that. Just said it's granulomatous inflammation, consider infective, non-infective, it's not a neoplasm, etc. So the patient returned to me and said, look, I'm not getting very far with the dermatologists. Can you help sort this out? So my feelings, just based on that biopsy, was it cutaneous Crohn's disease, which we see occasionally? Was it a fungal or TB infection? Was it pyoderma? So I admitted in myself. I arranged a repeat biopsy with cultures for TB and fungi. We did a chest X-ray. We did a urinary lamb, which we use for TB more in sort of our HIV positive patients, but we checked it anyway. It was negative. And none of these came up with any infection or anything further. So I made the call that this was probably cutaneous Crohn's disease. And I treated him with intravenous steroids followed by oral prednisone. And I dose intensified his infliximab to 6 weekly. So just a note about TB, because it's something we deal with on a daily basis. We have very high incidence of TB in South Africa. A lot of our IBD patients, up to 12%, have been treated for TB. And TB of the skin is well recognized, either as a direct involvement of the skin, or you can get immune-mediated phenomena such as erythema nodosum, erythema induratum. And that often can make the differentiation between Crohn's disease and intestinal TB very difficult, because they can really mimic each other. So anyway, I went ahead with his treatment, but unfortunately, he wasn't getting any better. What surprised me about him is that there wasn't much pain. His main concern was that, he's quite active and he hikes in the mountains around Cape Town, and that he was having trouble getting his hiking boots on, but there wasn't much pain. And I thought that was unusual for pyoderma, which generally is very painful when you expose the wounds. They generally, patients find them quite painful. Anyway, so we carried on. So for a few months, he was on 6 weekly infliximab, but he really was not getting better. And then he mentioned to me that he was heading back home to Oxford, which is where his family were from. And he said to me, could you refer me to a dermatologist in Oxford? So I contacted a colleague, Simon Travis. I said, please, can you recommend a really good dermatologist who can help give us an opinion here? And that was arranged, and I was waiting with great anticipation to hear what the esteemed dermatologist was going to tell us, and that all would be revealed. And all we got in a very brief note was, patient has a non-healing leg ulcer, use potassium permanganate soaks, add crystals to the water until the solution turns a light pink, and soak for 10 minutes every day. Not surprisingly, that really didn't do much for the leg ulcers, and they continued. And then he just mentioned to me that he was going to extend his holiday or his visit overseas, and he was not going to come back to South Africa. So when he finally arrived back here, he was now 12 weeks since his last infusion. And when he came into my office, I looked at his leg and I said, your ulcer's gone. And he said, yes, it seems to have healed in the last 4 weeks. And I said, you know what, you've got a paradoxical reaction to infliximab. And that was the diagnosis, a paradoxical granulomatous skin reaction to infliximab. So I've raised 3 points for discussion. First one is, how do we define these reactions? And what do we know about them? Do we know anything about them? And what would be the best approach in this patient who's got quite a complicated IBD sort of history? And now we faced with what appears to be a paradoxical reaction to infliximab.
So maybe we can go to Dr. Sadi again, and maybe you could tell us what the typical appearance and characteristics are of a paradoxical skin reaction to anti-TNF drugs. And, you know, was there anything in the workup that maybe would have pointed to this, or are there other things that we should think about ordering as part of the workup?
So the biopsy results showed a granuloma, which is very broad. I understand like the confusion. It could be necrotizing, non-necrotizing, and the differential here is huge. So the workup, which has been done by Dr. Epstein, was correct. You need to rule out infectious, you need to rule out autoimmune, neoplastic, and even drugs. So it's a broad differential that has been done. When we say paradoxical skin infections, usually these are a diagnosis of exclusion. So after we've ruled out everything else, we diagnose it, and usually to confirm the diagnosis, we re-challenge the patient. So we give him again the infusion, the anti-TNF medication, and this is when we know that actually it is a true paradoxical reaction. Usually for the anti-TNF, ulceration is not very common. This is a nice case. It's a nice report. We don't really see ulceration. What we see are mostly eczematous reaction or psoriasis. Now, the mechanism is not really understood because we know we do give such treatment for these inflammatory skin conditions. This is why we call it paradoxical. So the mechanism is not really understood, but this is how it happens. It's a paradoxical skin reaction. So again, what we see are mostly eczematous or psoriatic or psoriasiform reactions. So scaling, itching, dermatitic lesions and such. And sometimes it's very severe, like extensive over the whole body, which leads to stopping the therapy.
And this is a common question, but is this a class effect? So would you feel comfortable switching to another anti-TNF?
So usually you can switch. Infliximab, I think it's the most culprit here. Usually it's the one that causes the most, and this is part of the treatment. We switch to another one, but this does not mean they will not get the same reaction, but we can try.
And there's a question from online asking, not necessarily about the paradoxical reaction, but if this were true pyoderma, and the patient was already on a combination therapy with the anti-TNF, with good drug levels of the TNF, would there be a role for even trying to go higher on the TNF to treat the pyoderma, or would this be a situation where we would want to switch?
So higher, he should have responded. So going higher, maybe, I'm not really sure because I've never seen ulceration with on infliximab. The treatment that Dr. Epstein gave, the steroid, also should have helped. So we have a really good therapy to help pyoderma, and he did not respond. So again, this is why we question the diagnosis. And the biopsy does not really go with it. The granulomas does not really go with PG.
Yeah. No,
maybe another point, Ben, is just to basically not to take these lesions outside of the context of how well the bowel is doing, because that's when you start to differentiate a lot of these as possible reaction versus driven by as an extraintestinal manifestation of the disease. So somebody who's healed, who's completely well on treatment, is much less likely to have these kind of skin lesions that are more related to inflammation than to a paradoxical reaction that are driven by the IBD more than the paradoxical reaction.
Absolutely. Though I have seen patients, because we don't necessarily know whether it always parallels the disease activity. So I have definitely seen patients with PG and their luminal disease under control, which is obviously a very challenging scenario. So Dr. Sadeghi, so we have this patient, severe Crohn's disease with perianal disease, as well as ankylosing spondylitis, now has a severe paradoxical reaction to anti-TNF. How would you approach treatment for this patient now at this point?
I think the corticosteroids or other anti-inflammatory can help manage mild reaction, but for severe reaction, we should step up the class or change the class of the medication. For example, we use ustekinumab or other medication for this patient. Actually, I believe that the best medication for fistulizing Crohn's disease is infliximab. But in this situation, if the skin lesion is terrible to treatment, it's better we change the class.
So in 2024, we obviously have more medications now than maybe even when this was first occurring. What would be your next class that you would go to?
I chose ustekinumab.
Ustekinumab. And Dr. Khatoubi, what would be your agent of choice at this point?
Well, we have many options actually with the IL. I would go with the visankizumab, instead of the ustekinumab. But again, it is not wrong to go with the ustekinumab. I'm wondering whether JAK inhibitors can help in these cases, and I think it is not a bad choice. But I don't know. I mean, this is up to discussion. I think you can use anything, but I would use Riza, for this case, specifically with these ugly colon ulcers.
So tiebreaker, Dr. Sharara, what would be your choice?
Yeah, I think all of these are possibly effective. Just have to try and see. The idea would be to control the IBD now, because the skin is going to get better when you switch out of class.
I guess we probably need a rheumatologist also, since the patient has ankylosing spondylitis. I guess one of the concerns I would have would be because the IL-23 or 1223 aren't going to work so good for the axial arthritis, that may be a situation where a JAK actually is beneficial.
Yeah, I think adalimumab would be a reasonable option. One can try, certainly. It may not work for the skin or still cause the skin manifestation, but it may not.
Yep. Okay. So Dr. Epstein, take us what happens next?
Good. So I'll just sort of summarize some of the things we've discussed. So just the definition of these paradoxical reactions. It's just when a drug is approved for a specific indication, but has the opposite of what is expected. It can cause a manifestation of a new inflammatory condition or exacerbation of an existing. And it may be characterized by a condition that usually responds to this class of drug, like psoriasis and anti-TNFs, and any organ can be affected. Some people have proposed a classification according to true reactions like psoriasis, borderline reactions, and non-paradoxical reactions, which is difficult to make sense of. But I've just shown two cases that I've seen recently, which would fall under the borderline paradoxical reactions. I think that probably the most important thing about these paradoxical reactions is, number one, exclude an opportunistic infection. Make sure you don't have a reactivation of a latent infection. Always think of malignancy, particularly lymphoma, that can cause strange sort of skin reactions. Is this an extraintestinal manifestation of the disease? Is it anti-drug immunogenicity or lupus? I think those 6 items should be kept in mind before one decides this is a paradoxical reaction. We don't know too much about these reactions because they weren't described in the registration trials. They were first reported in 1997, and TNFs are most commonly associated, but we think that might be just because we've used TNFs for much longer, and that with time we may see more paradoxical reactions to some of the other drugs. There are no predictive biomarkers, and interestingly, I think, as you've mentioned, Ben, the disease is often in remission when these paradoxical reactions occur. Is it a class effect or drug effect, and do we understand the physiology? So just a practice point, and something that I've experienced, is that when one switches a patient from an anti-TNF to a gut-specific biologic, often one experiences these new problems, and whether one unmasks extraintestinal manifestations, whether patients develop de novo extraintestinal manifestations, or whether a paradoxical reaction is occurring in response to the new biologic. Sometimes I've been caught in that sort of scenario. But certainly we have seen some drug-related issues with vedolizumab. Is it a class effect or unique? So if we look at granulomatous skin reactions, they occur with all the anti-TNFs, and none are spared. And interestingly, if one looks at psoriaform skin reactions, they also occur across the board with all the biologics. So that can give us some sort of guidance as to where to go. Why do they occur? We don't really understand them. There's a latency of between 6 and 12 months. Typically, they occur when you've had a good therapeutic response to the biologic drug, and it's believed that you cause immune dysregulation in non-inflamed tissues, resulting in these paradoxical reactions, often affecting the skin. So how does one approach these biologic reactions, paradoxical reactions? Well, what depends on what condition you're treating, how severe the reaction is, and what are your therapeutic alternatives. And obviously, if there's a life-threatening paradoxical reaction, one has to stop the biologic, treat with steroids, and then one shouldn't re-expose within the same class or with the same drug. If it's a moderate reaction, one consider a switch within class or out of class. And if it's a mild reaction, then one can continue with a biologic and maybe just treat the reaction, and that would be a mild psoriasis. For my experience, most of them have been psoriasis-like reactions, and they've always moderate or mild. I've never encountered a severe paradoxical reaction. So this is just some data on patients with IBD who developed psoriasis on anti-TNFs. The majority of them, there was no change in treatment, and they were obviously treated just for psoriasis. 36 were switched within class, and really there wasn't much improvement when switching within class. And almost 100 were switched out of class, and with ustekinumab, 72% had complete resolution of the psoriasis, and with vedolizumab, which makes sense, 100% had resolution. So this just gives you an idea of with a mild issue like psoriasis, what the chances of improvement are in switching out of class and within class. So we had a long overdue clinical pathological meeting and a diagnosis. Once we all sat around the table of granuloma annulari was made, and we, on careful sort of review of the biopsies, there was the triad of degraded collagen, a histiocytic infiltrate, and the presence of mucin. And interestingly, granuloma annulari is an autoimmune condition which is treated with anti-TNFs, but also can develop when you're on an anti-TNF. So it's a typical paradoxical reaction in our patient. So as to future treatment, I made use of this table, which is from Beatrice Gars, who's really got these fantastic tools to help decide on care. And this gives you the list of drugs, what IBD they treat, and what extraintestinal disease they treat. So we looked at the options for our patient. So we could either switch within class, so adalimumab, which is available in South Africa, very affordable. Setrusumab is not available in South Africa, but those would be two switches within class. Or we could switch to a JAK inhibitor, but unfortunately at the time, upadacitinib, which treats both Crohn's and ankylosing spondylitis, was not available. Then we looked at IL-12, IL-23. So the only one available in South Africa at the time was ustekinumab. But as you mentioned, there is some sort of evidence to show that it's not very effective with axial disease. And there's a lot of debate as to why that is, because these seems to be IL-23 mediated diseases. So we're not sure why they don't work. There is some data to show there's benefit, but they're not registered for ANGSPOND. So those were the options available to us. So we decided this was definitely a paradoxical reaction. It was granuloma annulari. We were going to stop the infliximab. And in view of the severity of these ulcers, we were going to switch out of class, and we decided to go with ustekinumab, which seemed the most reasonable option available to us. So the patient was switched to ustekinumab, but unfortunately, both his gut and his joint symptoms deteriorated, and he had no recurrence of his leg ulcers, so his legs healed up beautifully, but he required oral steroids to get his gut and joints back into remission. And he said to us, look, he would rather have his ulcers back and his gut and joints in remission. So we decided to take the chance and switch to another anti-TNF, so switch back within class in March this year. And we obviously explained to him that there may be a recurrence of his leg ulcers, but he's done actually really well. He's been on 8 months of adalimumab at conventional dosing. His clinical and biomarker remission of his Crohn's and ANGSPOND is good, and this was a photo I took about 2 or 3 weeks ago, and he's had no recurrence of his leg ulcer, and he's quite happy with his progress. So it remains to be seen how long that lasts. But certainly a switch within classes seems to have worked well for us, fortunately. So just some final comments. I think we have to keep in mind that we successfully treat IBD, but we can also trigger. And although these conditions are rare, we just have to have an awareness for them. New knowledge for me was that paradoxical reactions occur in the setting of good IBD treatment response. Paradoxical reactions can certainly mimic extraintestinal IBD, and in my sort of case, I thought this was cutaneous Crohn's disease. And maybe an MDT meeting early on in the course would have given us a timeliest diagnosis, but the poor adherence, in fact, revealed the diagnosis in this case. And then the strategy for managing the reactions depends on the underlying condition, the type and severity of the reaction, and what therapeutic alternatives you have. And just about potassium permanganate, this is an old anti-disinfectant that was developed in 1857. And my experience with it has been working in rural South Africa, where mothers would often treat their babies who had diaper rash or impetigo with potassium permanganate. But apparently also a favorite of Oxford's leading dermatologists. And with that, I thank you.
So our teaching point is don't send your tough derm cases to Oxford. No, I'm kidding. Obviously, I'm kidding. But I think
Can I ask just a question? Can I ask a question?
Yeah.
Is he a smoker?
So he was a smoker before he presented with his first diagnosis and that's why we thought he had ulcerative colitis, because he developed symptoms soon after smoking. So he was an ex-smoker.
The reason why I'm asking, because these ulcers in the leg can be aggravated actually in microvascular because of the smoking, and that can aggravate actually the ulcers.
Yep, that's a great point. And I think this is really a great teaching case, highlights the workup around the paradoxical reactions to anti-TNF, and also the importance of good multidisciplinary care and working closely with the dermatologist to help manage and diagnose. And one of the most challenging decisions I find is that decision around whether to treat through the TNF paradoxical reaction or switch. I mean, maybe Dr. Sadi, just before we end, like, how do you approach when we should attempt to treat through it versus switch?
So it really depends on the patient, how comfortable he is, how okay he is with his symptoms. As I mentioned, it's usually eczematous, psoriatic reactions. So usually these are manageable. So we can manage them with topicals, and it's fine. So we wait, we give it time, and then we decide together with the patient. If he's really bothered, then we really have to change the medication, yes.
Yeah, so it's always a shared decision-making discussion, and depends on the severity of the IBD phenotype as well. But hopefully we'll have more and more mechanisms of drugs available to help us manage these side effects. So great case. And from there, we'll transition to our second case.
Hey, thank you for having me.
Thanks for joining
Thank
us.
you, Diana.
Bye.
So now we will go to Dr. Sadeghi for her case.
Yes, thank you. I would like to thank Dr. Ala and his team as well as Benjamin for chairing the session. Please, next slide. A 20-year, Nancy, please, next slide. A 20-year-old man with ulcerative colitis was admitted to the hospital due to abdominal cramping, bloody diarrhea more than 10 times a day, urgency, and pallor. 4 years ago, he was diagnosed with ulcerative colitis. At that time, a colonoscopy showed pancolitis Mayo tooth, and histopathology confirmed chronic active colitis with crypt destruction. He was initially treated with 3 grams of sulfasalazine and 5-ISA enema daily. 2 years later, the patient was admitted for an IBD flare, and after ruling out infection, his medication was stepped up to the infliximab and azathioprine. And he responded well until this current presentation. Next. There is no history of smoking, drinking, or appendectomy. Vital signs were stable, and the physical examination was unremarkable except for pale conjunctiva. In the emergency room, alongside requesting paraclinic test, IV hydrocortisone 100 milligram 3 times daily and enoxaparin 4 milligram subcutaneously were administered. Lab data revealed anemia with a hemoglobin level 9.5 and elevated ESR and CRP. Next slide, please. A colonoscopy. Next slide, please. A colonoscopy was scheduled, which showed loss of vascular marking, deep ulcers, and spontaneous bleeding consistent with pancolitis Mayo 3 extending into terminal ileum, backwash ileitis, and multiple biopsies were taken. Next slide. An early diagnosis of acute severe ulcerative colitis was made. What is your management plan for this patient diagnosed with acute severe ulcerative colitis? This is the first question. And what should we do in emergency department or when patient presented with this situation? What is our management plan for this patient?
So maybe we can start with Dr. Al-Darmaki, and then I'll go to Dr. Khatoubi. So you have a patient here with a history of UC, is already on infliximab and now presenting with acute severe UC. So what would be your initial steps in management with this patient?
All right. So first step is to make sure that there is no other etiology to the acute exacerbation, and excluding infectious pathology, including C. difficile and CMV colitis. So along with usually we would do flex rather than a full colonoscopy during the acute severe UC, and would take biopsies and continue the treatment with IV hydrocortisone and assess the patient in 3 days. Obviously, this patient is already on infliximab. So with this picture of very, very severe disease, it's probably arguing that infliximab is not working, developing acute severe colitis despite being on infliximab. So after exclusion of infection, another therapy should be considered, and obviously the surgeon should be alerted and consulted to come and see the patient, as this patient is at high risk of colectomy.
What other medical therapy would you consider for this patient?
So since the patient is already on IV corticosteroids and already on DVT prophylaxis, I think this is what is really needed at the beginning. Infliximab, you could send the level of infliximab, but anyways, I think having a very severe disease would push us to change the therapy to another agent. And one of the things which can be tried if infections are not there would be like JAK inhibitors can be tried, or cyclosporine if the case is not responding to steroids.
Dr. Khatoubi, is there any scenario where you would see yourself giving more infliximab for this patient?
Yes, definitely. Of course, in addition, was Dr. Damaki mentioned that to rule out infections, I would go immediately with a 10 milligram every 4 weeks, and we can go with the higher dose. And if the patient is not improving at that time, we can try JAK. And I also 100% agree to involve the surgeon from the beginning. So I would go with the higher, very high dose of infliximab, 10 milligram per kilo, and see how he does.
And Dr. Sharara, any difference in your thought? How do you, so obviously this patient probably in most ERs would get IV steroids while we're excluding the infection. They're on infliximab. Do you have any concerns about giving high dose infliximab, then giving a JAK inhibitor with the IV steroids?
I mean, it's always a question that we face with such patients. I think, clearly we have the 3-day interval to try to see if they do respond to the IV steroids. And that gives you time to basically rule out infection, which can, of course, play a role in this particular setting and can change what you do. I think the UC PREDICT study also has shown that maybe using a higher dose of infliximab is not necessarily associated with a better outcome. So I think most of us feel like we need to sort of go with the biggest dose possible, but I think the evidence does not seem to support that. So I think steroids for a few days, rule out infection, and then just make a decision about maybe switching treatment or cyclosporin or surgery. That always comes up into the discussion.
Yep, absolutely. And the cyclosporin in the United States, cyclosporin has fallen out of favor, but it is a very good treatment for patients with severe disease. And one of the important things is to make sure that you check lipid levels, magnesium, when you start to see if a patient is potentially eligible. And it's safe to give cyclosporin after infliximab, particularly if you've checked the drug level of the infliximab and it's undetectable, which my suspicion in this patient is that they have a high clearance and probably wouldn't have much infliximab in the system. So Dr. Siddiqui, what happened in the workup?
Okay. Next slide, please, Nancy. Biopsy results indicate the presence of active chronic colitis, and the cytomegalovirus IHC test came back positive, and the Clostridium difficile was negative. It means the patient could be considered as a CMV colitis that lead to acute severe ulcerative colitis. What percentage of the patient with IBD, this is my question, I have some question for this patient, what percentage of patients with IBD who are treated with immunosuppressive drugs may develop cytomegalovirus colitis or CMV colitis? And this is the main question, it's what is the gold standard for diagnosing CMV colitis? And actually, how we should treat the patient concurrent to antiviral medication with some medications such as immunosuppressive or anti-TNF or other medication that we use for underlying disease. And the last question is, how many IBD patients with CMV colitis may require colectomy? This is the main questions for this patient. Nancy, please, next slide. Next slide, please.
So Dr. Epstein, if you're seeing this patient, you have biopsies now that show that there's CMV infection in addition to the severe colitis. How does this change your management of the patient?
So these are always difficult patients, because I think the challenge that we have is the CMV a bystander, or is this the actual cause of the severe colitis, and we always ask our pathologists to answer that, which they don't really give us good answers to that question. So I think we are obliged, in someone who's so ill, to treat them with we would use ganciclovir to treat the CMV, but I think one probably has to also continue treating the IBD. I don't think treating the CMV and sitting back is always the wise thing. It's difficult. Will this patient, just get better? And do you have to withdraw some of the immune suppression? I don't think I would do that. When I was looking at this case, I think, surgeon daily assessments also very important, because, this is a patient who's, at high risk of maybe ending up with a colectomy. So, so I would definitely treat. Whether that would get me out of this tight spot, I'm not sure.
Yeah, I think the theme we've heard from everybody consistently is make sure a surgeon's involved. And with acute severe colitis, it's very important that the surgeon see the patient on the first day. I'm always very careful to explain to the patient why we're having the surgeon come, that it doesn't necessarily mean that they're going to need surgery right then, but it's always better to have the surgeon as part of the decision-making, so that they're not, if in the event that they do need surgery, that they're not meeting them as they wheel into the operating room, because that is the most stressful experience for the patient. Dr. Khatoubi, how do you approach the IBD management with the CMV findings on biopsy? So the patient starts ganciclovir. Are you simultaneously going to escalate their IBD therapy, or do you wait any period of time to see how they respond to the ganciclovir?
Yeah, I would wait. Usually we do try, we start the IV ganciclovir, and within actually 4 or 5 days, we should know that the patient is doing well or not. I would not escalate immediately unless the patient is not responding. And again, the big question, whether this is a bystander or an active infection, I don't think that will change the management for the IBD treatment overall, but infection has to be treated.
And Dr. Shah, would your approach be the same? And then I also want to give the parallel situation of C. diff, for example. So let's say this was a C. diff infection as opposed to a CMV infection. Would you do anything differently?
No, I think that's the other question. I think C. diff is also an important, opportunistic infection in those patients. I think treating, of course, is important, but often, as was mentioned, I think it's a flare of disease that also requires change in terms of intervention. But certainly one can give it a short period of time to see if the benefit is tremendous, for example, then one could basically pull back and then reassess.
Yeah, usually with C. diff, I'll give 1 or 2 days of Vanco, and if I don't see a response, then I'll escalate the IBD therapy with that. So Dr. Siddiqui, you want to take us through the answers to your questions?
Okay. And Nancy, please, next slide. Regarding the percentage of IBD patients who are treated with immunosuppressive, how many patients may develop CMV colitis, a retrospective study from US nationwide inpatient sample conducted between 2015 to 2017 analyzed approximately 1 million patients with IBD. The study found that 0.05% had CMV colitis. But in 2 small studies involving patients with acute severe ulcerative colitis, such as our patient, reported the prevalence of CMV colitis between 21 to 34%. Next slide. The primary challenge in treating patients with acute severe colitis is the lack of the consensus on how to define cytomegalovirus infection as a cause. It means the gold standard for CMV colitis is also debating. The relationship between positive virology test result and clinical disease activity is actually unclear. Many experts consider CMV IHC and tissue CMV PCR quantitative to be more relevant in diagnosing CMV colitis and base their treatment decision on these tests. And CMV colitis is classified in 2 classes. High-grade CMV, it means tissue CMV DNA more than 250 50 copies and more than 4 inclusion body. That means these patients require antiviral therapy and possibly anti-TNF concurrent therapy for the underlying disease. But in patients with low-grade CMV, it means tissue CMV DNA between 10 to 250 copy and less than 4 inclusion body. Antiviral therapy is needed only if the patient has very severe symptoms. It is also debating. Some experts like to treat with antivirals such as ganciclovir in both class, even low grade and even high grade. But many experts believe that it is better we consider ganciclovir for high grade CMV or low grade CMV plus in very symptomatic patients. And next slide. In response to the question, would you treat underlying disease while using antiviral? The answer is yes. The underlying IBD should be managed concurrently. However, this is controversy regarding the initiation or continuation of the treatment. The majority believe that immunomodulators such as azathioprine or MTX should be discontinued in case of systemic CMV disease. Furthermore, it is recommended to initiate or continue anti-TNF therapy, discontinue immunomodulator, and taper off corticosteroid. The preferred antiviral agent is IV ganciclovir, as you mentioned, at the dose of 5 to 7.5 milligram per kg for 2 weeks. But as Dr. Katubi mentioned, it's better we start for 1 week and then we can de-escalate and followed by oral valganciclovir at the dose of 900 milligram taken orally twice daily for 2 to 3 weeks. And next slide. In case of ganciclovir resistance or intolerance, such as myelotoxicity, foscarnet may be used as an alternative for a duration of 2 to 3 weeks. But we barely use this medication. Actually, patients who have high-grade CMV colitis have a high risk of colectomy. In fact, about 14% of patients with IBD who develop CMV colitis may require colectomy. And however, those with high-grade CMV colitis may benefit from antiviral treatment, that this antiviral treatment leading to lower colectomy rates.
Thank you. A great overview of CMV. And, I think a point that I always think about in practice is the CMV itself is usually just a marker of severe disease. And oftentimes this is a harbinger of the patient's going to need surgery one way or the other. So again, the point being that if a surgeon's not already involved, the surgeon should be involved at this point, because even when you treat through, this is usually the marker of a severe disease course.
More heavy immunosuppression, and that's why these patients get that. I just wanted maybe for the audience to just also point out the paper that Anita used in as a reference. There's a great review by my colleague here at AUB, Dr. Fadi Murad. It's called Ulcerative Colitis and CMV Infection from A to Z. It really addresses all those issues. It was published in JCC in I think 2020. So yeah, very good reference for most, I think.
Great.
And can I ask a question from Ala?
Yes.
How you manage low-grade CMV colitis?
Yeah, I'm not sure that we're really doing this at this point, counting the number of inclusions or on the immunohistochemistry, trying to look at those. Like you said, I think usually how severe is the patient, if they're deep ulcers. I mean, I've had the opportunity to also diagnose CMV in bone marrow transplant patients, and really the presentation is different. They're punched out deep ulcers and they're separated by normal mucosa. I mean, here the picture that you showed is what we see classically for an acute severe ulcerative colitis with CMV on top. I know one cannot differentiate endoscopically, but generally deep ulcers and heavy immunosuppression, I think predating the disease makes me certainly give CMV more of a weight in those patients.
Yeah,
And
also, if I may add one thing, sometimes we see esophageal ulcers and even gastric with
Sure.
CMV, not related to the IBD, but this is all, immune suppressive medication effect.
Yes, yes.
and you taper off the corticosteroid and actually discontinue azathioprine or methotrexate or continue.
I think if they're responding to your anti-CMV, antiviral therapy, I think it makes sense that one could diminish the immunosuppression, as we do often with any patient who's immunosuppressed. But I think my impression that most of these patients do not have this, fantastic response to the antiviral, and it's their, IBD disease flare that is also playing a significant role. It's not easy to basically read out which one is playing a role. That's why we treat both, really.
Thank you.
These are always tough cases. So two great teaching cases for today and a great way to wrap up 2024. Ala, do you have any closing comments for everybody?
No, thank you to the presenters. I'm so glad that this span or the scope of IBD Academy is spreading across the whole region into Africa, Iran, hopefully in other countries. It's great to have everybody involved, and I wish everybody, a happy holiday season and happy New Year, and hopefully we'll see you all again in 2025.
And I would also like to thank our silver sponsor, Johnson & Johnson.
Thanks for having me.
Thanks very much.
Wonderful seeing
Bye,
everybody.
everyone.
Thank you,
Thank you.
everyone.
Thank
Thank
you.
you. Thank you.
Bye-bye.
Stay safe. Thank you. Bye-bye.